Okay, I'm gonna jump in and get going while we wait for everybody else to sign on. Good evening, everybody. Thanks for joining us. I'm excited to welcome you to session 3 of our Island Dermatology series. And Dr. Weichert is going to be presenting Dermatitis, Variants in Management. I'm Chris Morrow, Director of Island Medical Programs Physician Education Program, which we fondly call PEP, and we're so happy you're here with us. Just going to start with a brief land acknowledgement, and then I'm going to introduce Dr. Weichert. I'd like to take a moment to acknowledge that we're gathering on a computer in a funny sort of way, but also on the lands of the Coast Salish peoples. I'm calling more specifically from the area of the Lekwungen speaking people, so that includes the Songhees, the Esquimalt, and Wasanix people. And I think it's important to note that we mentioned this last time, that there's a lot of wisdom in Indigenous peoples too regarding skincare, and lots to learn if you ever get an opportunity to ask one of your patients. And it would be very interesting to hear some of their treatments and cures, and to acknowledge those. So we are super lucky to have Dr. Gabrielle Weichert today. She has a very impressive introduction, so hold on tight, everybody. She has a degree of biology at Waterloo, followed by a PhD in physiology, and then med school at McMaster's, and then a 5-year residency in dermatology at UBC Derm. So I didn't ask you, Gabby, but that sounds like 17 years of
That's exactly right.
yeah,
Post-secondary, yeah.
that's pretty incredible. Gabby is the medical director for Skincare West in Nanaimo, which is our now beloved dermatology clinic, because we know they provide excellent care, but they're also really great with helping us provide education. And she works with a range of skin conditions as a consultant. She focuses on general medical and surgical dermatology and some cosmetic treatments. Um, this can range from concerns regarding skin cancer, inflammatory disorders, and there's many new modern therapeutics, including phototherapy for psoriasis and eczema, and other treatments to provide optimal care for quite complex diagnoses. She is also the vice president of the Canadian Dermatology Association, and foolishly, I think, has agreed to be the president next year. She's an examiner on the dermatology board exam, and she's obviously eminently qualified to present for us. So we really appreciate your time, Gabrielle. And I'm gonna do a couple of housekeeping things. So we'd love it if you guys could stay muted, just because we have so many participants. But we would be even more happy if you turn on your camera. You don't have to, but it just gives a little more sense of community, and it's a bit less unnerving for a presenter than speaking to a bunch of blank screens. We're going to do our questions in Slido, and I'll have Leah give you the Slido link and introduce how to do that in a second. And we'll hold most questions to the end for a moderated Q&A session. And you can use the chat if Dr. Weichert asks you any questions and wants some quick responses. Please use the chat for that. We are recording this session as well. We've got an hour scheduled, and we hope to finish on time, although it's possible that we might go over a few minutes for the Q&A. And if that's the case, I just want you to know to be comfortable looking after yourselves, and if you need to log off, that's fine. Leah, did you want to just mention the Slido?
Sure, I'll just reiterate what Chris just said. If you have any questions throughout the session, if you could just post them in the Slido link that I'm about to post right now. Perfect, and it should be there. If you follow that link, you'll have a place to put your question, and Dr. Weichert will address them at the end of the talk. So thanks very much, and I'll hand it back to Chris.
Okay, thanks. So let's go for it, and introducing Dr. Weichert.
Thank you. Thanks everybody for joining. I hope you have a warm tea or an early supper in hand. So thanks for coming out on a rainy night. I have a lot of slides and it's a complex discussion, so I'm going to move really quickly and here we go. Okay, so let me. For some reason, I'm not advancing now. Okay, yeah, all right. So in terms of my disclosures, I do have I do speak as an advisory on advisory boards and speaking with honoraria to a number of different pharmaceutical companies linked to dermatology, but I'm not financially involved in any of these companies. Our objectives for today are to just discuss very briefly the morphology of, eczematous dermatitis, and to discuss ultimately some of the novel systemic agents to be aware of, because that's a very rapidly changing area. And then at the end to talk about, why my patient may be not doing so well and when to refer, and all things in between to talk about eczema, basically. So dermatitis is, an inflammation of the dermis. That's the itis of the dermis, and really just means eczema. We have a few variants that I'd like to discuss tonight because they're the most common ones, and they're listed here, and I'll just be addressing those in order. Oh, here we go. Okay, so eczematous dermatitis has some classical features where we have erythema, we have lichenification or thickening of the skin where there's been a lot of scratching and inflammation. There's excoriation where you get erosions from just chronic scratching, and then the epidermal scale. So those 4 features are part of the process. What some mimics that are just worth knowing about, tinea, like these are all papulosquamous disorders, meaning that they're inflammatory and they generate scale on the surface. And here are a few others which have slightly different morphology. Tinea, which would have the advancing annular scale on the peripheral border. Psoriasis being more symmetrical and having more of that thick, very adherent scale. Scabies is also dermatitis, but obviously of a different cause. From the scabies mite. Squamous cell carcinoma in situ and actinic keratoses, also focal scaly lesions, but SCC in situ being more solitary, actinic keratoses being very diffuse, and it's very complicated when I get an elderly patient with eczema and actinic keratoses and lots of sun damage, because sometimes you don't even know which one you're treating focally. It's tricky. And then, of course, cutaneous lupus can also be red and scaly. So just some other mimics to be aware of. It's not always eczema. For those of you who have dermatoscopes, I just thought it might be worth mentioning. If I'm hearing a lot of family doctors, primary care clinics have dermatoscopes now, and I think they're just a wonderful tool. If you haven't been taught this before, a scabies burrow, if you think you might have a scabies burrow, you can pull out your dermatoscope and you can see on the upper right-hand corner, you can see the scabies mite visibly using your dermatoscope. It looks like a little, like think of a moth against a window. It has that sort of a moth shape, if you will, very tiny. But if you can visualize that little speck at the end of what you think might be a linear burrow such thing on the wrist or foot or such, you've got your mite. You don't need to do any scrapings or take a biopsy or anything. You've got your diagnosis. So that's just a little tip about using dermoscopy to diagnose scabies easily. I've stopped doing scrapings mostly for this reason. Okay, so just a little mention, skin of color can present very differently, and we should just be aware of that. It doesn't have the visible erythema that people of lighter skin have. So we just need to be conscious that we probably undercall skin of color when it comes to how active the dermatitis is. And also there's much more hyperpigmentation, of course, as well. So when we're learning more about how to evaluate skin of color as we go. Keep going the wrong way. Sorry about that. So to speak more about nodular dermatitis, that's my first variant. Nodular dermatitis is Latin for the word numulus, which I think means money, which means coin. So coin-shaped dermatitis, nodular dermatitis. That's why it's called that. And typically you have these very discrete areas of eczematous dermatitis, and it can throw people off a lot. It sort of makes one think about tinea because it's focal and scaly. Some people think it's psoriasis because it's so plaque-like in discrete areas. But if we look more closely at the exact morphology of these specific plaques, they are in themselves eczematous. They're cracked on the surface. They're not very thick and plaque-like like psoriasis. They're a little bit diffuse and shaggy on the edges, not as well demarcated as psoriasis. So it's not always clear what these patients have. But the classical patient is often a middle-aged man for some reason, usually sometime after the age of 50. They're super duper itchy and they're miserable. They sometimes have a history of atopic, dry skin type thing, sensitive skin, but not always. They often present first time in winter, but by the time they get around to referral, it could be any season. But when I ask them, it usually would have started in the winter months when things are drier. Because people love hot showers on sore skin and itchy skin, they'll often exacerbate it by, having a nice hot shower all the time to make themselves feel better. But hot tubs can be part of the exacerbation as well. So just some things I look for in history. But the management needs to be super aggressive to get on top of that eczematous dermatitis, and then they need to manage it. So I usually do a short course of a high potency topical steroid like clobetasol, and they have to be very aggressive with it, like very, thickly layered, twice a day for sure. And they can get better very, very quickly. And then they need to transition to supporting the epidermis so that it fully heals. And so they need to continue with moisturizing creams, sometimes for up to 3 months, and then avoiding those exacerbating features like hot tubs and hot showers. So just some education around that. Okay, so, and this tendency, I tell them, like, this is you now. This is you from now on. You need to be aware that this could recur. And as soon as you get a hint that something's happening, back to the moisturizing creams. And then if you need to, back to the steroids for a short course. I would say 95% of people get better with this approach. And the other 5%, we need to do more things. Okay, I'm having some technical troubles here. Okay, moving forward. Contact dermatitis. So contact dermatitis is what touches your skin and then causes a problem. So contact, right? And there's two categories. There's irritant and allergic contact dermatitis. So irritant dermatitis is like pretty much anyone can get this if they have the right stimulus. So it's usually chronic dehydration of the skin leading to inflammation. It's most common in people who have sensitive skin or atopic dermatitis background, but the classical one is hand dermatitis. And then it's anybody who washes their hands frequently. Mothers, parents, healthcare workers, kitchen workers, restaurant workers, anybody who has that repetitive wet, dry cycle of the hands can tip into dehydration and have contact dermatitis. And then the other type is allergic contact dermatitis, which is a type 4 delayed hypersensitivity reaction where there's an allergen involved. And that allergen then is lifelong memory within the T cells. And we'll talk a little bit more about presentation of those. So the hand dermatitis here, as you see it, this is the typical thing. It's usually dorsal hand. That's where the dehydration happens most readily because the skin is thinner there. If it's just on the palms and not on the dorsum of the hands, it's probably more in the atopic realm. But the back of the hands, almost always some component of irritant overwashing or dehydration. And the maceration underneath that ring, often, again, just a contact dermatitis in the fingertips as well. Okay. So allergic contact dermatitis, it's usually acute, but it can be chronic. It can occur anywhere from 2 days to 2 weeks after the inciting factor is exposed to the skin. On the top photograph, you see that linearity that's usually associated with a plant-like contact, like poison ivy, for example. That linearity is there. It's usually an eczematous presentation, but when it's really acute, there could be bulla and vesicles, like you see in the upper photo. This is my patient below, and I'm just curious. Think to yourself for a second what you think this was bilateral, by the way, what you think the potential trigger was for this patient and what the allergen might have been. Quick thought, throw it in the chat box. I'll give you 10 seconds to think about that. What could the problem have been, maybe? And difficult because she was Filipino and she had a lot of significant hyperpigmentation after it settled, and that had to fade over a year, but it was incredibly acute when I met her. I'm not looking at the chat, but maybe Chris, you can throw some ideas at me. Do you see the?
Yeah, we got a mask, blush, makeup, headphones, hogsweed, dye, nickel in a cell phone. Those are the responses.
Those are great. All great. I've seen nickel. I've seen cell phone allergic contact dermatitis. In her case, it was nickel, but it was her eyeglasses. She had metal eyeglasses that she wore. And as soon as she was aware and she could switch to plastic eyeglass frames, and she did fine. So yeah, but it was so raging. It was just really, really astonishing. Okay, so the classic nickel allergy is the snap on the jeans coming in direct contact with the skin just above the belly button. Any rash right above the belly button like that is almost always nickel allergy to something in the pants. And then of course in the same photo you see the wrist. So they had the watch allergy too, with nickel underneath the back of the watch. Obviously a sandal pattern on the lower picture. So rubber accelerators are a common allergen in footwear. This patient on the other side had an allergen to a preservative in her hair products and causing quite an extreme facial dermatitis. And strangely enough, they don't always have a scalp involvement because the scalp is a bit thicker, but the facial involvement is there. So I keep going the wrong way. What's the difference? Mayonnaise versus your creams. Why is mayonnaise in the fridge and your creams are not? It's the same, it's oil and water emulsified together. So why does mayonnaise have to live in the fridge, and why do your creams sit in your cupboard for 3 years and they don't spoil? I mean, Think about it, right? So all creams any personal care product you have that has water in it has a preservative in it. That's why it doesn't spoil. So absolutely anything you have in your cupboards, in your shampoos, in your hair products, in anything that is a personal care product that is liquid has a preservative in it. That's why it doesn't rot or spoil. And so in addition to that, there's fragrances, there's stabilizers, there's emulsifiers, there's a number of ingredients that can be really problematic to people who can be sensitized to them. And what's really perplexing to patients is that they could use these things forever and never have a problem. And then all of a sudden they do. And they say, well, I've been using this for years. But at any point they can become sensitized. And once they are, they're allergic, and that is forever. So that's really frustrating for patients to really have to live with. Okay, so this is the top 10 allergen list from 2020. This is the most recent comprehensive list we have, and we'll be getting updates as we go. But the North American Contact Dermatitis Group consolidates the most common allergens. This is the top 10 group currently from 2020. So the blues are all preservatives. So the top 10 of the top 10, we have 4 preservatives that are in personal care products that are causing problems in people. And then the fragrance mix, and linalool is one of those kind of like pretty smells that are in a lot of personal care products as well. A fragrance mix is a mix of about 10 different fragrance products that they put all in one so that they can test patients that way, because there's a lot of cross reactivity between fragrance as well. So once you're allergic to the fragrance mix, then that's really problematic because you have to avoid all fragrance. And then the others are there too. Propolis is beeswax, and Burt's Bees and all those types of products. Anything that has a tacky lip balm type preparation to it could have propolis in it. So that's a common allergen as well. Balsam of Peru is things that are tacky and sticky. And there's a number of personal care products like that as well. Okay. I'm moving along. Emerging allergen, acrylates. I mean, which 16 to 30-year-old these days isn't playing around with acrylic nails, right? It's super duper common. And now, people are gluing eyelashes to their face with glues. And there's a new thing I just heard about called lamination of the eyebrows, where they'll like glue the eyebrows in a position and perm them in that place. So these things are everywhere, and our young women and men are playing around with a lot of these cosmetic things. They're going to cause a lot of problems for allergens in the future. Interestingly, if I haven't mentioned it to you before, you see a lot of products, they'll say paraben free, and that's a big marketing thing. Paraben free, like it's supposed to be very reassuring that they don't have paraben, which is a preservative. I've heard chemists in the dermatology world, people who study this, they say if paraben would have persisted as a preservative, it's far less allergenic than all the preservatives that were developed to replace it. So paraben-free is a marketing ploy. All the other preservatives that were ultimately developed also have a great deal of troubles with allergens. Okay, so what do we do? What do we do if we suspect somebody might be allergic to something in their personal care products? Well, if they're determined to know, I'll say try doing a use it test, where they would just put the product on the soft area of their inner arm for several days in a row, and just wait and see. If they don't rash up, they're not allergic, because you're allergic in your whole skin. You've got memory T cells floating all through your body, and so you're going to be allergic everywhere. So if you don't get a rash, it's probably safe to try. And also, obviously, we just want to simplify everything. We'll move them away from anything that has potential fragrance and high-risk preservatives. If I can't get a patient to sort of settle from that, we can consider doing something called patch testing, which is done by an allergist, but the wait is long, at least 6 months, and often it requires a referral from dermatology to even be seen for patch testing. They won't take direct referrals always from family doctors, and that's really frustrating. Toughest thing is when we determine an allergen that's within their occupational environment and people have to consider switching jobs. Well, that's really difficult. This is what patch testing looks like. There's a standard North American tray of 50 allergens, which will be put in little chambers and then put up against the skin in these adhesive strips. They have to be on the skin for 2 days. And then the stickers are peeled off. And then we wait a further complete 7 days before we do the reading. And the reading looks like the other photo, where we look like little circles of red dermatitis on the template, and we try to determine which of those might be allergens. And then there's special trays that the patch test people do. Like, let's say you have a hairdresser or a dentist, they have got special allergens in their occupational environment that they can add. Sometimes there's up to 70 or 80 stickers put on to try to do this patch testing. It's a very involved process. It requires at least 3 visits with the doctor to do it properly. So it's a lot of work, especially when people have to travel to get this done. So what I normally do in that is just try to limit potential allergens first. It's much easier. I'll switch them to Dove sensitive bar soap. Anything that's a liquid soap, again, will have a preservative in it. And it's really difficult to even find, liquid soaps are so popular, right? All those gel soaps you have in the shower. They all have a preservative. They often have fragrance. So we'll move just to Dove sensitive bar soap, plain. No natural products. People love natural products. It's got lavender. It must be natural. It's good for you. So all the botanicals are potentially allergens as well. So we need to move away from that. Get away from the vitamin E's, anything that smells pretty, anything that's botanical or natural. My neighbor makes this cream. It worked well for me. Like those are common things I hear from people. We need to stop all of that. Fragrance-free house. There's so many fragrances in the household these days. There's diffusers that you plug in. There's those air fresheners you spray all over the house if you've got a dog or a pet. All that needs to go as well. There are a few preservative-free moisturizers that are worth knowing about. Obviously, Vaseline jelly, no preservative in that. It's just the ointment, so that's super safe. There's a couple of products I've listed here that are some of the products in the product line are in a special bottle where it can only squeeze out but not be contaminated in. So they are actually preservative-free completely. And these are all available at Shoppers Drug Mart. So they just need to go speak to somebody who knows the brands well. And often there's employees at Shoppers Drug Mart who know the products well and can direct the patient, you know, I want something that is free of preservative, and they should be aware of that. There's a shampoo called Free and Clear. It's hard to find. It's on Amazon, so that's helpful. And it is a shampoo that doesn't have any fragrance and has some less of the allergenic ingredients that some shampoos have as well. And when it comes to fabric softeners, there's lots of fragrance-free choices out there as well. So I do that first. I try to eliminate everything. And maybe then they're not actually being exposed to anything that could be a potential allergen. So that could be helpful and may negate the need to refer them to an allergist. Okay, moving along to another situation. So here we have a patient who is post-op hip, and suddenly, you know, you get a call that you've got a patient who's got bilateral cellulitis of the lower legs. And you're thinking to yourself, is that right? And so this is stasis dermatitis. Here we go. The typical patient has a number of other features that you'll be looking for. They'll often have varicosities, hemosiderin deposition, that orangey stain on the lower legs from extravasated red cells. Atrophy blanche refers to an area of a healed superficial ulcer. It kind of looks like a porcelain white stellate scar from a healed ulcer in the area. Patients who have terrible lymphatic drainage and stasis can develop elephantiasis nostra verruca, which is basically this incredibly lumpy elephant-like skin on the legs, which is chronic. Lipodermatosclerosis is chronic stasis dermatitis, and eventually there's it's almost like a hide-bound skin, very, very tense, and they call it the inverted champagne bottle. That one leg you can see that. It's very wide at the top and narrows very much at the bottom. There's a lot of sclerotic skin changes. Why does this happen? Two major reasons: bad calf muscle pump. So people who are just not very mobile due to various mechanical reasons, they're not very mobile. They don't have a good calf muscle pump because they're just not flexing their foot. They're not walking vigorously. They're shuffling around. They're not getting blood to flow back very quickly. And then, of course, once you have some valve damage to the veins, you're going to get more stasis and pooling. And so it has to do with extravasation of the leukocytes that sort of then get trapped in the fibrin outside of the extravascular space. And then when they break down, they release a lot of inflammatory mediation. They think that's the reason why there's inflammation. So managing this, it's the same as managing any dermatitis. You might want to do a short course of high potency topical steroids, usually 1 to 2 weeks, but then the moisturizer helps to support the surface skin. And then how do you really keep them well after you get through that exacerbation? It's all about, often, like, compression is the key, or at least elevation, draining the static edema in the lower leg and blood flow so they can elevate their legs. And it's really important. People think elevation means they put their foot up on a chaise lounge or on a lazy boy chair, but to really think about it, it's physics. If you need drainage, then the point of drainage needs to be, you know, the ankle needs to be above the heart, basically, if you're going to get proper drainage. So they need to understand lying flat and putting your feet up on a pillow is better than just propping it up on a little, you know, chaise lounge or something. Compression is really tricky, and it's a bit of a science, I suppose. If a patient has good palpable pulses and they're not diabetic and they don't have a history of coronary artery disease and they can walk vigorously, then I'm feeling comfortable to prescribe prescription grade compression stockings. But if none of those things are correct, I'd need ankle brachial indices to be measured to ensure that I have good flow. Otherwise, I could create gangrene in their arterial occlusion if we compress them. So we just need to be aware that that's a good treatment, but not in every patient. There's a lot of trickiness with respect to wearing compression because of people's ability to access their toes readily, to reach their toes easily. So either they just might have mechanical difficulties in strength, or just maybe they just can't reach their toes very easily. There's a number of assistance devices that are out there. You just need a really good medical pharmacy that knows how to help people with the assistance to get these things on. And there's a new product that I just came across on the lower corner here. It's kind of like a Velcro applied compression system that a patient told me about, actually. And I think that's brilliant because they can just kind of Velcro the whole thing on, and it does create the same compression. So that's kind of neat. So lots of ideas there. Okay, let's talk about atopic dermatitis. That will be the bulk of the presentation from here on in. Atopic dermatitis being our genetic eczema that starts in childhood. Again, quite patchy in childhood, off of facial involvement, and patchy elsewhere. And as they get into childhood, it's going to concentrate more into the flexures of the arms and legs, and then also the hands and feet often. And then into adulthood, hands are always a problem, and it's just a bit unpredictable where else on the body. It could be focal, it could be diffuse, it could be flexures, it could all sorts of different patterns, but it does change a little bit. And a lot of kids will not be as terrible as they are in infancy as they move into childhood. So that's always nice to think that it probably gets somewhat better. But everyone's different, and we do have lots of cases of quite severe dermatitis in older people as well. Okay. And all right, so first I'm going to just share some slides from one of my colleagues in Ontario, Melinda Gooderam, who has done a lot of presentations with respect to the kind of the quality of life impact of moderate to severe atopic dermatitis. And just to talk about what we're calling now basically the atopic burden, and we're delving more into understanding how this affects people. We know that people with chronic eczematous dermatitis, atopic dermatitis, have a lot of skin pain. We didn't really appreciate that until we started asking it. Pruritus is a huge problem. It's probably one of the most difficult symptoms of this. It's obvious to others, so it's quite visible. And there's a chronicity to it, obviously. So it's just, it's such a long-standing problem. It's very fatiguing. It's very draining. We also know that people are prone to infections on the surface of the skin, just bacterial impetiginization. And you think about, do I need to use an oral antibiotic? Do I need to use a topical antibiotic? And very rarely, but I've seen it many times, eczema herpeticum. So this is when a patient develops a herpetic, regular old HSV infection in their eczema, and then it just can spread like wildfire because of the open skin. And these are usually very punched out little erosions that would be typical of sort of a localized herpetic eruption, but it's really diffuse. And this requires quite aggressive treatment, especially if it's on and around the face. So what are we not seeing? Because we don't ask. There's a number of things to consider within these complex atopic dermatitis patients, and I'll go through them a little bit further. Over 70% of people report having at least one wake up at night in moderate to severe atopic dermatitis. And we all know how important sleep is for a number of health measures, both mental and physical. This is very common that people will come into my office on their first consultation with literally a bag, sometimes, 20 products, 10 products that they've tried before, be it their moisturizers or their different creams, and they have no idea which cream is which. Sometimes they'll have multiple jars of the same cream. They won't know that that's actually the same prescription, just in multiple different bottles. So there's been a lot of attempts to try to use different things. 47% of people report avoiding physical activity. I'm not surprised. It's very irritating, the sweat, when you sweat in atopic dermatitis, and maybe they also just don't feel that confident in being in a sort of a group environment for exercise as well. People report up to 2.5 days of missed work per month from moderate to severe atopic dermatitis. 32% report missing important family life events because of their active skin disease. And the family impact can be quite severe for children with atopic dermatitis. And this is true for any chronic illness in the pediatric realm, as you can imagine. It requires a lot of work by parents. And there's also an impact on how the other siblings are getting attention, or, the parents' ability to kind of juggle all of that. Sleep disturbance is very, very common. If a child's not awake, if the child's waking up, so are the parents, almost always. There's a financial burden to all of the medications, and also, the work that's being done to help the child with their skin. So it's a big deal. Bullying, stigmatization, you can imagine our teenagers in particular, and even our adolescents, when they're in school, they can feel unconfident, and people can make lots of comments about their skin. 64% of adults report anxiety, 44% depression. And to talk about skin of color, there is a significantly increased risk of more severe atopic dermatitis, both in the Indigenous and the Black population. This data is from a few different resources, including the USA. Because of the darker skin tones, we are underestimating, using our standard scoring systems, we're underestimating the extent of the atopic dermatitis in darker skin colors. And in the center column, patients don't agree with clinicians' assessments. Typically, I think clinicians are underestimating the quality of life impact on patients in patients with skin of color because they just don't see it as being as inflamed. So we have to do better there. So in general, this was a clinical quality program that was international. Multiple countries were involved in consolidating this information, but basically we're learning that clinicians are underestimating the burden of atopic dermatitis to patients and family. Patients find the scoring systems that we use really hard to understand, and they're unsure how to answer many of our questions, including quality of life, et cetera. And clinician and patient reported outcomes, should both be considered to reflect the skin disease burden and how we should approach treatment. So it's not up to me to decide necessarily how much this is impacting you and how aggressive we can get. It should be a real collaboration between patient and clinician. Treatments, let's talk about that. This is a busy slide. I appreciate that. But this was the European consensus guidelines. And I kind of like this new way of presenting things. And I've seen it in other medical approaches. But dark green, if you look at the key at the bottom, dark green means everybody in the group agrees that's a really good idea. And the lighter the color means there's less consensus about the recommendation. So pretty much all the things presented here were a global consensus among the group regarding we would all agree that's a really good idea kind of thing. And so moving from the bottom to the top, baseline therapies, we're just talking about, moisturizing creams and avoiding allergens, et cetera. And as we move into mild eczematous dermatitis, we're using topical steroids, topical calcineurin inhibitors, and wet wraps. I'll speak about those a bit more in a moment. As we get into moderate, we're starting to include things like phototherapy. And as we get into more severe, we're starting to consider systemic agents, and I'll speak about those as well. So these are just some of the fields that I'll focus on a little bit more thoroughly, just so you can understand what I'm talking about. This is another way of looking at it, kind of from left to right. We have topical medications, and I'll go through these classes. We have conventional systemic medications that we have always had, and they're not actually indicated for eczematous dermatitis. Prednisone is, but the rest aren't. We're just using them off label in eczematous dermatitis and hoping for the best. And then the new targeted biologics, both injection and small molecule targeted therapies, I'll speak to a bit more. And this is where all the work is being done, and it's really exciting. Okay, so moisturizing creams, super duper important to support the epidermis from being, dried and cracked, and to help the skin heal and be as closed and tight as possible to prevent exacerbations. I don't endorse any one brand, but I just mentioned here are two common things that we recommend. Vaseline jelly being a very common thing, especially for little people, and then a nice thick cream. I tell people it should be in a jar with a screw lid, because anything in a pump lotion probably has less occlusive properties. Although it's very popular for people not to want to use any kind of, creams that are at the drugstore, and they like things that are natural, and coconut oil and olive oil kind of things are very popular. I try to, these people are usually that are coming to me are still very active. So I try to say, well, how's that working for you? Not very well. So maybe we can try this for a while. And if you want to go back to that when things are well, that's okay. But I don't think they work that great. I was in London Drugs today just by chance, and I thought, let me take a look at creams. These are 5 brands that you might know, and these are heavily marketed to the consumer when you're at the shelf, because they're all up in center. This is all you can see are these types of products. But I'm just curious, I'd like all of you to just think for a sec. They're all about the same price. What do you think one of these, just a 450-gram jar, what do you think one of these costs at London Drug? Just throw it out there. Just throw out the number. What do you think? What do you think on average one of these will cost to the patient? Just throw it in the chat box.
$25 is what we got twice.
25?
24.
Okay. Yeah, so close. These are all about $30 at London Drugs, each one of them. And if we know that covering the skin once, kind of head to toe in an adult, takes 30 grams. And if they're going to cover themselves all over, let's say, using a 450-gram jar, that will last them 15 days. And so if they're going to need 2 of these jars a month, they're going to be spending $60 a month just on moisturizing creams. They haven't even bought a prescription yet. So there is a huge cost barrier for patients. And I think that it is a real challenge because creams are expensive. Cheapest thing at the drugstore is Vaseline. It's about a third of the price of the others. And Vaseline also has a product called, well, it used to be called Vaseline Creamy, but this is the closest thing I could find to what I used to call Vaseline Creamy. It's Vaseline that's whipped up with some water, and it's also very inexpensive. It's, again, about a third of the cost of the others. But if you go to Costco, which I also did today, by the way, Costco has always a couple of good eczema brands. And as you can see here, you get two for the price of one. So it's literally 50% less at Costco to get a nice big jar of plain eczema type moisturizer. So that's just another tip. Not everybody has a Costco membership, but that's another tip. So these things are expensive. In the UK, if you have a diagnosis of atopic dermatitis, you get all your moisturizing creams free. And in the UK, the use of steroid topical prescription creams is way lower than it is in North America, because they're getting free moisturizers, and that's doing the bulk of the work. So, you know, we don't cover moisturizers, unfortunately, but it shows you the importance. Bathing. There's no consensus on how often to wash in atopic dermatitis, but we think it should be somewhere between 2 to 7 times a week, daily or a few times a week, but it should happen. I have a lot of patients who even feel so uncomfortable in their active dermatitis that they avoid showering because it hurts. But it's really important just to hydrate the skin, but also to just help, remove some of the bacterial burden on the surface. It doesn't matter to me if it's a bath or a shower. I think baths are probably better, but they're both pretty good. A child shouldn't have any bath products in there with them, no bubbles and all of that, just plain soap, and minimize that too. But the most important thing in all this whole story is right after they get out of the tub, within 10 minutes, they need to get cream everywhere they have eczema. That's really super important to this whole process. And if any of you have children, and if any of them have ever had eczema, you know what a slippery seal that child is. Basically, you've got to lock and seal the door. You've got to lay towels on the floor, because as soon as you start, that kid's all over the wall, and you probably almost got to wear your own suit, because you've got to change yourself afterwards. The creams are everywhere, but it's necessary. But I agree, it's messy. I get it. It is, but it's important. Bleach baths are a thing. You've probably heard of them. Bleach baths are very helpful, particularly for people who have a lot of surface infection, a lot of excoriation, because they probably have a high staphylococcus burden. There's a link here below. HealthLink BC has nice instructions about bleach baths. Basically, it's about a half a cup of household laundry bleach in more or less a full tub of water. Dilute it first, let it all swish through. I call it a mini swimming pool. And they just soak in there for their 10 minutes, and just to avoid the face and the eyes, just in case there's any irritation there. But that can be really helpful. I've also seen studies that refute the value of bleach baths and just say soap and water can be as effective. And I kind of believe that's probably true. But I have seen lots of success with bleach baths as well. If you haven't heard of wet wraps, it's worth knowing about. It's a really, really important concept that can be super helpful, especially for young children. And if you just remember the term wet wrap, there's lots of stuff on the internet. YouTube has videos as well. But the concept is you bathe the child, you dry the child, you cover the child in their cream. But after you've done all the bathing and creaming, you then put them in a little suit. This could just be a cotton sleeper like all the babies sleep in. But the key is that you put that in the water and you soak it and you wring it dry. And then you wring it dry. So it's just super damp, but not dripping, but it's damp. It's a damp, warm cotton suit. And they put that on over top of all the creams and whatnot. And then you can layer that with a nice warm pajama and put them to bed. And this can be done in adults too, in some kind of adult version. I know adults don't have big onesies, but you can get cotton long johns and cotton long sleeve shirts that will do the same job. And there can be a dramatic improvement in epidermal healing just with even overnight, but over a series of these wet wraps in a row can be super helpful. It's a lot of work, but it's worth it. Okay, topical steroids, I say pick your favorites. There's about 30 topical steroids out there. And I always say to the residents, why do you think there's so many topical steroids out there? And you sort of ponder, you think, well, why are there so many topical steroids out there? There's at least 30. And the answer is marketing. I think every pharmaceutical company who makes topicals wants a piece of this market. And so they just came out with new molecules and tried to capture the market share. They're not magic. There's nothing special about all these topical steroids. Pick your favorites. And these are my favorites. For a mild steroid, hydrocortisone up to 2.5%. My medium is betamethasone and my high is clobetasol. And this represents 96% of my prescribing of topical steroids. I prefer ointments because they're more occlusive and they work better. But if a patient hates sticky, greasy creams, sticky ointments, I'd rather they take a cream prescription than not use an ointment at all. So that's a concession I will have as well. But I try to encourage the ointments, maybe even just for the first prescription. You're really active right now. Let's do this for a week. And then in the future, we can switch you to creams if you'd prefer. So the non-steroidal topicals. This is an area that there's being a lot of research and there's new ones coming down the pipeline. But this is the cluster that we have right now. These are non-steroidal creams approved for eczema. The calcineurin inhibitors include tacrolimus in 2 different concentrations and pimecrolimus. So the difference is that tacrolimus is an ointment and, in my opinion, more potent. And the pimecrolimus is a cream. So some people prefer the cream because it's just less, it's less sticky. And then there's the phosphodiesterase inhibitor, crisaborole, came out a few years ago. I don't love it. I don't think it works great. I don't think it's been a replacement for me for the others, which I'm more familiar with and more comfortable with, but it's there. And there are more on the way. What's the disadvantage? They're not that potent. I would say that the relative potency is only about as high as 2.5% hydrocortisone. So they're not better. They're just not steroids. They're also expensive. And they come in small volumes. A small volume of like a protopic prescription is going to be pushing 150 or more these days for that prescription. So it's a huge difference in cost compared to the steroids. But the advantage is that there's no steroid side effects. There's no atrophy. There's a certain comfort level in certain families and patients about, I'm not using a steroid on my skin. It is a bit burning and stingy in some patients. There can be kind of a warmth feeling. Not the patient's fault. It just causes a warmth feeling. So I often warn people about that. It's the cream, not you. So push forward because you might get the benefit from it. Dermatologists can get special authority for the calcineurin inhibitors, but I don't know why, but family doctors cannot. And one thing that we do know is that you can use these creams prophylactically. Like, for example, if somebody has flexural eczema all the time almost, and maybe you get them better or clear, then they can use these creams twice a week, even when they're mostly well, to avoid major flares. And there's good longitudinal studies showing that the total amount of cream used in a year is much less if you do kind of twice a week, a little bit of an application, as opposed to letting it go through big flares and using a whole bunch for a long time and then getting it under control. I don't know how often people do this because it's something else to remember, but it is helpful. Narrowband UVB phototherapy. This is the contemporary phototherapy that we're using now for skin disorders. Most of our patients have psoriasis, but I do think that in my experience, after about 15 years of doing phototherapy, my prediction is that about 60% of people with an eczematous rash will find significant benefit with phototherapy. Phototherapy is covered under the medical services plan, so it's an insured service, and there's no limit to the number of treatments per year. We usually treat 2 to 3 times a week during active clearance, and then for maintenance, we'll either go down to once a week or then even just stop when they're better. Yeah, the problem here is access. Like, where are the booths? I know that in Victoria, you have to go through dermatology to access a booth. Peppered up and down the island, there are a few family doctors who are offering phototherapy because they purchased a booth knowing that there's a bit of a treatment void in their geographic area, and they're able to offer phototherapy in their offices. There's one in Duncan, and there's one in Qualicum Beach. There's now one in Port Alberni, and there's now one in Campbell River, and those are all run by family doctors. And of course, in Nanaimo, we have 2 running in our office as well. So this is for people who are really adverse to considering systemic treatments and the creams aren't really doing the work, then this is a great option as well. And it's super safe. I've reviewed 30 years of international data on narrowband UVB, and there's no signal for skin cancer because it's just one ray of light. It's 311 nanometers, which causes apoptosis of lymphocytes in the epidermis, in the dermis. There aren't lymphocytes in the epidermis. And that's how it works. And for whatever reason, the 311 nanometers at the energy levels we're using to treat skin disease is not causing any malignancy transformation with 30 years of data. But maybe 50 years of data will show us differently, but right now it seems to be quite safe. Okay, and just a little bit of data on that. These are 2 different publications, but I like the visual on the left. This is something on the left on this axis. The SCORAD is one of the scoring systems we use for eczema. This patient cluster started around a SCORAD of 30, and you can see after half a year or so that they had, sort of a 2/3 improvement, and then that tapers off a little bit with time, probably due to lack of compliance. I'm not entirely sure. And in a separate paper from 2022, about 50% of people thought felt they responded well to treatment, and that's not significantly defined here, but I think that trend is pretty much represents, I quote, people at about a 60% chance of it being helpful. Systemic agents. These are our traditional systemic agents that we did use for atopic dermatitis, and the only one that's kind of on label is prednisone, and the others are off label. So they were never Health Canada approved, but we know that they work. Methotrexate is probably the one we use most commonly because we're so comfortable and familiar in using methotrexate, and it's got a relatively safe profile. But does require monitoring, obviously. Once we get into cyclosporin, we know that we're burning nephrons, and we just don't want to use it for any longer than about 2 years. And it requires a lot of intensive monitoring, a lot of blood work. Have to measure blood pressure frequently as well. And all of these have risk of immunosuppression and infection, etc. Azathioprine, I don't like to use that often, but I do sometimes. It has a higher risk of lymphoma with chronic use. And mycophenolate, Mofetil, Celsep is very expensive and hard to get often, but I have had special authority cover it when all else fails. So those are kind of our traditional options. But what I'd like to talk a little bit more about is kind of the new systemics that have come down the pipeline that have been really helpful and much more efficacious. So I'm going to start with the injectables, what we call the biologics of atopic dermatitis. And there are 2 on the market right now. One of them is called dupilumab, and it's targeting a couple of different interleukins that are affiliated with the atopic dermatitis pathway. And the other one, which is tralokinumab, which just blocks the IL-13 pathway. And these are both available. They're both injection medications, kind of like the biologics are. They're injected every 2 weeks. And we can expect somewhere between a 50 to 70% global improvement overall. There's about a 10% chance of conjunctivitis, which is kind of odd. They just get really almost like an allergic conjunctivitis, and we don't really understand why that happens. Right now, unfortunately, the government just recently declined dupilumab, the better one, which is more efficacious, declined it being covered in BC, although every other province in Canada has this covered for patients with moderate to severe atopic dermatitis. So once again, BC has made a decision different than the rest of the country, which is really frustrating. But we are going to be working to appeal that because we think it's a very, very safe and therapeutic medication. It is now approved up to the age of 2 and above. And I know a lot of my colleagues in other provinces who have a really high burden of pediatric eczematous dermatitis have just found this incredibly helpful in managing their patients. So right now, the only patients who can access it are those with a drug plan. Moving towards the JAK inhibitors. JAK inhibitors have been used a lot in rheumatology, and you probably have patients who are on them used for joint disease. But we now have a few agents that are specifically designed to treat atopic dermatitis. But it's the same mechanism of action. It's the Janus kinase inhibition, which blocks cytokines, and there's different sort of specificity to that JAK-STAT pathway that's being targeted. But these 2 therapeutics are approved for atopic dermatitis. The first one being upadacitinib, and it has a couple of different concentrations. And this drug is already approved for rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and now also approved for moderate to severe atopic dermatitis, 12 years and above. And another medication similar is abrocitinib, and it's also approved for age 12 and above, and specifically has an indication for incredibly quick control of pruritus, although both will do that, but it sought the indication for that as well, so that's exciting. These are pills. Couple of clinical photos to share with you, front and back of an adolescent, and you can see the differences is usually, the data is usually presented in about the 12 or 18 weeks. So it's very impressive. This is a patient after 16 weeks, and an easy 90 score means that their eczema scoring system went down by 90%. So it's very impressive just after 16 weeks when someone's been struggling for a long time. We are currently waiting for the government to decide whether this therapeutic class will be approved under Fair Pharmacare with some caveats. Again, it'll have to have failed this and that, possibly methotrexate and other systemics before they're approved for these novel therapeutics. Right now, only patients with drug plans or those that are being bridged by the manufacturer through a compassionate program have access. They have to have quite a significant eczema score. You don't really know what this means, but this means quite bad eczema, basically. And they're in order to be bridged and under the compassionate program, they have to have failed at least one systemic agent already and optimized topicals and phototherapy. But we see even better improvement with this, at least 75% improvement within 3 months. And the itch can be gone within the week. Sometimes we're seeing just an incredibly dramatic drop in itch almost immediately. It just knocks the itch pathway out of the park. It's amazing. There are some monitoring issues here. The common side effect profile is here. We actually see a weird signal for acne. upper respiratory tract infections. We see a risk for shingles reactivation, so shingles vaccine is recommended, and we're monitoring white count as well, because there can be some abnormalities that we're looking for there. But not a bad profile for an incredibly effective drug. I thought I'd include what I kind of call the grab bag of ideas here, because you might have heard of these over the years, and I just thought I'd knock them off. Currently, the data we have on probiotics, vitamin D, fish oil supplements, and omega-3s, and dietary restrictions, we just don't have any good data. I do have a few patients who've said, well, I stopped dairy and nuts and soya and I don't know what other allergens people like to stop. And I feel like my skin got better. And I think that's a very episodic observation. It's not predictable. And I think that's why it hasn't really borne out in larger studies on atopic dermatitis. So we don't really endorse that, because some patients will actually go a little bit overboard and start getting into almost like an eating disorder state they do like really complex restrictions that aren't always that effective. We thought about 10 years ago that moisturizing babies from birth would reduce their risk of atopic dermatitis. And there was a paper that supported that. Babies were covered in Vaseline for the first, 6 months or 12 months of life. And the paper was really encouraging. And then they tried to replicate that, which is really important to do. And it was never replicated. So whatever we thought that signal was about doesn't seem to be true in real world experience, or at least with, replicated studies. So right now we can't say that moisturizing babies will prevent them from getting atopic dermatitis, except for a very small subset of high risk, high family incidence of atopic dermatitis, and only if they were moisturized within the first 8 weeks was that relevant, but not otherwise, not otherwise for these kids. So that was interesting. There are 2 studies that support the idea of melatonin, anywhere from 3 to 6 milligrams, and it helped improve their eczema. So maybe they were sleeping better, maybe they weren't scratching as much. I don't know. This has to be replicated. These studies weren't very. There's only 2 studies. It hasn't been replicated globally in other places, but it's an interesting observation. I don't know how strong it is or how much we can put behind it. Dust mite allergy is super common in these kids. So keeping the room clean, vacuuming, and also considering dust mite pillowcase, dust mite mattress covers could be helpful as well. And if they have pets in the family, they may or may not be allergic to their pets, but pet dander can collect a lot of dust mites as well. So just making sure the house is really clean of pet hair is really important. And this is kind of a complex statement down below, but I went to an incredibly interesting presentation at the European Academy of Dermatology in Europe this fall, where they were giving great data to show that it seems that food sensitization probably happens in the skin. So you guys know this more than I do, but feeding babies food 6 months plus is a good idea to preventing allergen early introduction. But it seems that if they were to get exposed on the skin first, they actually have a high chance of sensitizing to the same food. So through the skin can cause allergy, through the mouth, eating it through the GI system is a good introduction, but the skin is not a great introduction. So if you have a high risk, I know they're kind of joking in this presentation, if you have a high risk child, high strong family history of atopic dermatitis, then maybe you should think about washing your hands before you handle your child. You've been handling foodstuffs or cooking in the kitchen, maybe just make sure your hands are clean when you handle your child. So a bit tongue-in-cheek, but it seems to be really important to manage the eczema well, because they can get sensitized through the skin for food allergy. Okay. What if a patient just isn't getting better? A couple of things to think about. First, and the first comment, I don't mean to be, like, oh, don't use prednisone by itself, but I get this all the time. Patients will be referred to me, and the only thing they've been given is prednisone. And the topical management piece is so critical to long-term management. Of course, they're going to get better with prednisone in the short term, but there has to be all the other pieces in place to help the patient along further. There's a lot of topical steroid reluctance. You guys hear it as much as I do. And so just a matter of, gaining that trust with patients. And sometimes when they say, well, this cream doesn't work, I'll say, well, how, I really have to dig into the history. How much did you use it? Well, I used it twice and it stung, so I didn't use it any longer, or, such. So maybe they just didn't have an adequate trial of the treatment you're trying to put them on. So that's important to delve into that as well. And I think instructions can be very confusing to the patients. There's a lot to talk about when you have a visit with an atopic patient. There's so many pieces to talk about, and they may not remember all those pieces. And there are so many times that pharmacy will over-counsel patients on the risks of topical steroid creams, and then they'll come back and they won't have used them. So I'll say to them, sometimes knowing, almost predicting this, particularly if I know they need to be really aggressive with a steroid cream just for a very short time, I'll just say, look, I'm going to give this to you. I want you to put it on like crazy. And anything the pharmacist tells you, I just want you to, ignore. And I'm going to see you back, just so that we make sure we can kind of close the loop of whether they're doing it properly. And not to be disrespectful, pharmacists are super duper important, and they have so many roles, and they can be so helpful in so many realms. But that's just one piece that I've seen time and time again is getting scared off by the pharmacist about the risks of steroids when I've already kind of, considered that risk in my prescribing. Sometimes the topical steroid potency could be increased from low to mid to high, and then back down again as you kind of improve. So if someone's not getting better, I would just switch potency for a short time and see how they go. The volume is really important. You need 30 grams to cover the body once. And if they have an extensive chronic dermatitis, again, they're going to need, a 300, 400 gram jar just for a couple of weeks of treatment sometimes. So just volume sends a message. If they just get a small 50 gram jar, they may think, well, I need to make this last for the next month, and they just won't put too much on. But if they get a bucket of the stuff, they can be a bit more liberal and maybe have a feeling like, well, quantity sends a message. I'm going to use more of this. I've got lots of it, and I'll do that. Are they avoiding all the irritants and allergens that they could? Also important. And then are they moisturizing? So many patients, and I get it. This is a chronic condition and nobody likes to moisturize. It's sticky, gets on your clothing, etc. But it is a really important piece of management. So it just needs to be reiterated again and again. And if they're not prepared to do that, then we might have to just step up the therapy to something in the systemic realm or in phototherapy, just to get, past the topical piece if they're not willing to do it. Okay. This is a slide I borrowed from another talk I had done for a pediatric audience, a pediatrician audience, but it was kind of like, what do you do with that unhappy teenager, or pretty much any patient who has kind of just given up and they don't know what to do? I usually do something called a 2-week intensive plan. And I basically take whatever they're doing and I have to add a new idea. So sometimes that's increasing the potency of the steroid, for example, and I have to give them enough. I have to give them a generous amount. And then I give them very graphic instructions, like, you're going to be greasy like a seal. I want you to apply it like jam on toast, and you're going to hate me for 2 weeks, and you're going to wear your old pajamas at home, and you're going to be very sticky, and your clothes will need to be washed. But people can usually get behind a 1 or 2 week aggressive treatment plan. And then if that doesn't work, I have more ideas. Don't worry, I've got more ideas. If this doesn't work, I've got something else for you. So just don't give up, and have them back in a short period of time to see how it's going, and then you can step down if needed and kind of come up with some long-term support plans as well. I find teenagers get a bit worn out with all of this because they just don't want to be different. They don't want to bother with the creams. It's just too much. But again, they need to take ownership. Their parents might have been helping them, but it's time for them to take a step into the ownership of their own skin management. If they want to get better, they'll have to step up. So instead of speaking to the parents, I need to really focus on the child and make them autonomous to their condition. Okay, when to refer. So basically, you're doing all the things. And so when you've optimized all of your recommendations and the patient is still quite active and they just aren't achieving their full quality of life that they could, and because of that, it's negatively impacting their life, poor sleep, uncontrolled itch, possibly not able to have, steady employment, etc. Because they can be very emotional and upset, and it's very fatiguing, exhausting. It's time to refer to get some of these ideas into place. If there's an allergen suspected, they're still very active. If I have an atopic dermatitis patient who has just sort of been grumbling along, I've always had eczema in my flexures, etc., but all of a sudden I have an explosive eczema. So is that an exacerbation of atopic dermatitis, or have they now been sensitized to an allergen because they're at higher risk? Then we need to kind of, eliminate. But if I'm still suspicious, then they might need to be patch tested to see if they have now acquired, in addition to their atopic dermatitis or separate to, an allergic contact dermatitis that needs to be identified and avoided. Unfortunately, patch testing is often only really received when it's referred by a dermatologist, and that's a huge barrier to access. There are and allergists do this, and the only dermatologist in the province who does this is an academic dermatologist in Vancouver who does it as part of the academic program, and her waitlist is over 2 years. I can usually get in people for patch testing on Vancouver Island through the Victoria allergists within about 4 to 6 months, so that's not too bad. And those patients who are willing to consider phototherapy or systemic agents. I mean, if that's an absolute non-starter for patients, then, it's hard to get by. But if you're thinking, you're really active, we've done everything we can, you're optimizing your creams, your moisturizers, you're still miserable, would you be willing to consider taking something internally? And if the answer is like, heck yes, then please send them our way, because we're really excited about some of these new therapeutics. And if that's not accessible to the patient, we have some of our standard therapeutics that we can apply as well.
Gabby, I'm just going to jump in here. We are at the hour. Oh my gosh, beautiful. You are amazing. And so we're going to, yeah, right on the nose. So we're going to stick in for a little while and answer some questions. So go ahead and use Slido. If you're having trouble with Slido, you can put them in the chat, and we'll take about 15 minutes. And as I mentioned, no harm if you have to leave. And then any questions that we don't get answered, we can send along to the group the answer afterwards. I'm wondering if there might not be too many questions, because that talk was so amazingly comprehensive and answered many questions as you went along. So I'm going to just start with a couple of the questions in the chat, in Slido, and then if anybody else has some, please feel free to add them. So the first question is, how do you treat lipodermatosclerosis?
So that's a really difficult thing to treat, because there's a lot of scarring already under the skin, and there's different things in literature published for that, like horse chestnut extract actually has some data. It's a supplement. Pentoxifylline, which I call the drug that doesn't have a disease. What I found the most effective actually is intralesional steroid injections right into the sclerotic skin. I've had actually the most improvement with that. And the funny story is, I had a patient who came to me from another province, and he said, well, I need this injection. I said, well, I don't really know that that's a treatment for that. And then I looked it up, and it is. I just really wasn't familiar with it. And I started doing it on my patients, and they found it to be incredibly helpful. Not so much, it doesn't reverse the condition, but it really reduces the discomfort of it focally, because it's actually kind of painful for some patients. It's uncomfortable.
Excellent, thank you. The next one, if you want to go back to slide 86, there's 2 questions on that.
Okay. I don't know if my slides are numbered.
Oh, it's a picture. It says, why did the middle image B look better than the last image?
Is it this one? No.
Why did the middle image B look better than the last image C?
Yeah, that was the slide that the person.
Yeah, you know what? I see what you're saying. I guess it's a matter of like where you look, because actually here, this is active still, and this is active, and here to me it's not. It's just got a little bit of pigmentation, and yet there's a bit of an exacerbation up here. So I agree with you. It's a bit worse up here, but it's kind of globally better in other areas. And you know what? That's eczema. It'll do that.
Great. Awesome to have a clinical answer right in front of us. That's so cool. Okay, what should you do about parents that are worried about the black box warning for tacrolimus regarding cancer, even though it hasn't been shown in topical use?
You can tell them it's been removed, because it has been.
Oh, easy answer. Great answer. Who can prescribe the biologic inhibitors? Is it only dermatology?
Anyone. The tricky part is, though, that the company, like, if you have any patients on a biologic for anything, we are really helped out by what we call the patient support program. So every one of these has a patient support program that helps navigate the patients through complex insurance issues, and also answers questions to the patients independent of us, and anything that's super medical they'll throw away anyway from the patient support program. But the long and the short of it is, if you're out there and you're thinking, man, that's exciting, I would love to access one of those for my patient, I would probably just start by prescribing it, at which point it'll probably go through their insurance. But more importantly, if you have an astute patient who's willing to do the work, I would say look up who makes this medicine. Let's say it's tralokinumab, it's made by Sanofi. Dupilumab, which is the better one. Dupilumab is made by Sanofi, and they would have a website that would have an easy link to the patient support program, and they should be linked with the patient support program, who will definitely help them navigate the insurance issues, and even perhaps consider them for a compassionate program, et cetera. So yes, I would say the injection medicines are so safe that they could be prescribed by anyone, because they don't have any monitoring or side effects. They don't inhibit the immune system at all. I call them immunomodulators, not immune inhibitors. but they're really expensive. So, you know, the insurance is the biggest problem.
Excellent. Great answer. And I'm just loving how the complex names just roll off your tongue. You're the only one who can say them, probably. So here's a really good question. Is dyshydrotic eczema with the small blisters different from what you mentioned as irritant dermatitis?
I was going to include some hand dermatitis cases, but I knew I'd run out of time. So maybe we'll make that a separate talk sometime, Chris, because it's very specific and requires a bit of a unique approach and has some unique therapeutics, actually. But to answer your question, dyshydrotic eczema, which I don't like the name. It basically sounds like you're not sweating properly, and it has nothing to do with that, right? Dyshydrotic. It has nothing to do with your sweat glands, but basically it's usually like an explosive blistering, bubbling type, you know, skin on the palms of the hands in particular. And it's extremely, I don't find it's necessarily runs with the atopic dermatitis spectrum patient. It seems to be incredibly random and episodic in those who have it. And it's an incredibly frustrating presentation because people will just have terrible exacerbations that are out of the blue, completely unpredictable, nothing they've done. And it can be debilitating sometimes. So I don't remember what the question was, but it's a drag. That's a tough diagnosis to manage for sure.
The question was, how is it different from irritant dermatitis?
Oh, good question. Okay, so irritant dermatitis is usually kind of red and scaly, shall we say, red, scaly, and flaky, etc. But dyshydrotic / vesicular dermatitis / Pomflix, kind of all the same name for the same condition. Pomflix, I think, is a Latin derivation for bubbling over, like a bubbling pot of water, and that's kind of how I think it looks like. If you've seen that, like it almost looks like there's deep-seated blisters coming out of the deep layers of the skin on the hand. I think it's the dermis that's inflamed and is trying to push through the very thick epidermis on the palms. So it does look a little bit different. It looks almost they don't form true blisters though, because it isn't really a blistering disorder. It's really edematous and inflammatory, and it's trying to push through the palms of the skin, and it looks like like the skin's trying to boil out of itself, but it doesn't ever really make frank blisters, except on the lateral fingers. Sometimes it does there, tiny little deep-seated blisters. So
Amazing.
it's a wee bit different. Because
and would you follow like as a primary care provider, you follow the same treatment ladder?
Do I follow the same treatment ladder for that condition?
Yeah.
It often requires prednisone. That's tough because I try not to prescribe prednisone to any of my atopic dermatitis patients because they'll love it so much that they'll wonder why you don't give them more. And I don't want to have that whole conversation in the long run. I think we can do better with better things in the long run. I think it's safer, but in Pomflix type difficult acute hand dermatitis, sometimes the only thing that will get them through that flare is a short course of prednisone, and then they'll go back to baseline, actually.
Okay. Great. Is it possible to get contact dermatitis at a site distant from the actual site of exposure? In other words, can the reaction occur on this distant site?
Okay, so the answer is yes, but they would also have a reaction at the site. Okay, so there's a term called autoeczematization, or it used to be called the id reaction, which was a shortened term for something called the dermatophytid reaction. In these historical dermatology textbooks, it was shortened to what they call the id reaction, but then they renamed it better, called autoeczematization, which basically, I think really from a scientific point of view, you'll have the contact dermatitis where you're exposed, so there should be a localized dermatitis. But I think what happens is that those inflammatory cells go hematological and start honing into skin in other locations. So, for example, if you have a really raging stasis dermatitis, you can have eczema all over your body related to that exacerbation locally. So sometimes a patient will come in with a terrible kind of generalized eczema, but when I finally get them undressed to examine them, it's really raging on the lower legs or lower leg from a stasis, but that's caused sort of a hematological spread through some, T cell hematological spread, and then honing back into the skin through some receptor mechanism. So yeah, the short answer is yes, but you'd also have it at the site of the contact.
Fantastic. Thank you so much. Okay, I think this is our last question. So, do you see dermatitis under the eyes? I saw this in a 12-year-old with dry skin under the eyes. Looks like an allergy, but without any other allergy symptoms.
Yeah, it's a super common location around the eyes, like top and bottom. So yes, and the short answer is yes. I think if it was a child and, Can it only be on the eyes? Well, I've seen it sometimes. And I always ask about hay fever symptoms, because if they are exacerbated by seasonal allergies, and sometimes just that inflammation around the conjunctiva will kind of like overspill into the skin, so to speak, but the trigger might be actually the hay fevers. But independent of that, they can just have atopic dermatitis on the face and around the eyes as well. Yes.
Great. Well, I think that's it. I think we answered all our questions. If anybody thinks of any questions moving forward, you feel free to email Leah, and we'll pass them on to Dr. Weichert. I just want to thank you so much for an incredible talk, and thank you everybody for joining us and for all of your time. And we can sign off.